This is Learning Plan 9, Care of the High-Risk Newborn. We're going to divide this learning plan into 2 class recordings. One is going to focus on the issues related to prematurity, and the other will focus on the other issues that create a high-risk newborn situation. So first of all, about 9% of all newborns are sick enough at birth that they require some type of intensive care. And nurses can care for babies with minor illnesses in the mother-baby unit. But when we have more serious problems, they require care in very specialized nurseries. And that's where the NICU care comes in, Neonatal Intensive Care Unit. This is like an ICU for tiny neonates, and this gives them the best chance of survival. Here is the list of all the different issues that create a high-risk newborn, and the first part of this class recording is going to focus on number 1, the preterm infants, which really covers a huge amount of issues and problems. And then the second part will focus on the rest of these other situations. So first of all, preterm infants are also called premature infants. We don't want to confuse them with low birth weight infants. Both preterm and low birth weight are the leading cause of infant deaths. Low birth weight does not necessarily mean that the infant is premature. It means that the child has a lower birth weight than what they should have for their gestational age. The cause of preterm infants is unknown, but all of the risk factors in pregnancy are causes of complications. And the best thing we can do is try to prevent it from happening in the first place, and that's by our patients receiving adequate, routine, early prenatal care. So let's talk about those low birth weight babies. Preterm babies are, just by definition, usually low birth weight. Preterm infant is a live-born infant born before the 38th week of gestation, or a baby who has a weight of less than 2,500 grams. And about 7% of the live births of Caucasian population are low birth weight. But look at the African Americans. We have a 14%, so it's double that incidence in that age or in that demographic. So we really need to be focusing on what's going on and what can we do to prevent that. Low birth weight babies account for 80 to 90% of all the infant mortality that occurs in the first year. Now, we not only have low birth weight babies, but we have very low birth weight and then extremely low birth weight, and that are extremely very low birth weight. And you're looking at those 500 to 1,000 gram babies. So just to keep this in perspective, a 3,000 gram baby is about a 7-pound baby. So you're looking at some very, very tiny little infants. Now, common characteristics of preterm infants, so we just have a general idea of what they look like. Generally, if we look at their appearance, they look very frail, weak. They have underdeveloped flexor muscles and underdeveloped muscle tone, so they don't hold themselves in tight flexion. They lay there rather limp and almost frog-legged. Their skin is very thin and it appears red. And actually the definition of that is described as ruddy, R-U-D-D-Y, very red skin and almost transparent with very clearly visible blood vessels. Looks like a road map when you look at their skin. And lack of sub-Q fat. The pinna of the ear is soft and flat. They have absence of creases on the sole of their foot and little, if any, breast tissue. So what we're really looking at are many of those signs of gestational age that are evaluated in the Ballard assessment. When you look at the genitalia, the female, the labia minora and the labia majora are equally prominent, and the labia majora does not cover the labia minora at all. With the males, you have a smooth scrotal sac with little to no rugae, and they very well may have undescended testes. When we look at their behavior, they have very little energy for maintaining their muscle tone. Their suck is very weak, and they have a very feeble cry, and they become very exhausted from little things such as noise and just the routine activities that we are doing with them. Now, they are prone to problems of every body system and every body process because they are really not meant to be outside of mom yet. So look at all the different things that we can see as specific problems of prematurity, and we're going to go into more in depth in each of these. So we start with thermoregulation. Now remember, we talked about thermoregulation back in second semester. This is a heat loss issue, and it's much more significant. We said every newborn is at risk for heat loss, but it's much more significant in preterm infants. It becomes a much bigger problem because their skin is very thin and their blood vessels are very, very near the surface. They have decreased sub-Q fat, and remember that special brown fat that newborns have that allows them to do non-shivering thermogenesis, where the brown fat is very vascular, and therefore you have much more heat production as the blood flows through it. However, preterm infants have much less brown fat. Their body surface area is 5 times that of the adult, and they don't hold themselves in nice tight flexion, so they have extended extremities, which increases their exposure to the air in the environment, which cools them down. Also, their temperature control center of the brain is very immature, and it may be further impaired by asphyxia that may have happened during the delivery process. So when you look at complications of heat loss, complications are much more likely in preterm infants than full-term infants. So you are much more likely to see hypoglycemia, metabolic acidosis, pulmonary vasoconstriction, impaired surfactant production, and the calories that they use for heat production are then no longer available for them for their growth and weight gain. So they have problems with gaining weight because they're using every bit of their energies and calories just to stay warm. So if we look at assessment, what do we see that indicate that we have problems with thermoregulation in these preterm babies? They will have a much lower temperature, and we need to monitor them consistently, continuously, try to maintain their skin temp between 96.8 and 97.7. You'll see hypoglycemia and respiratory distress, and that may be one of the very first signs that they're having problems with their temperature. Remember, anytime you've got a cold baby, we've got those cold stress issues, and they require a lot more oxygen, and that's why you see respiratory distress. You'll also see poor feeding or intolerance to feedings, which basically means that they are regurgitating, not retaining their feedings. You might see lethargy or the opposite, irritability, poor muscle tone, and mottled skin. Now, temperature instability is also the first sign of infection, and infection may be one of the primary reasons that that patient went into preterm labor in the first place and then delivered a premature baby. So we have to assess for any other signs of infection. So we'll see those usual things of low temperature, but are there any other signs of infection? What are the lab values showing, etc.? Nursing interventions. We need to maintain a neutral thermal environment. We need to judiciously use radiant warmers or incubators to keep that baby warm, but also keep doors closed and keep traffic near that infant to a minimum. Use warmed blankets, use warmed oxygen. We often use kangaroo care and swaddling, that skin to skin, to keep that baby warm and wean them to a crib only when they're stable. I have seen teeny, tiny, tiny little neonates with thermoregulation problems where we actually wrap their extremities in saran wrap to try to keep their heat in. But we also have to watch them for overwarming. We don't want to cook them because we could increase their metabolic rate, and that increases their oxygen and glucose needs. So it needs to be a neutral thermal environment. However, tiny premature babies, and any premature baby for that matter, are more likely to be low temperature than high temperature. The next problem we can see with premature babies is hypoglycemia. Remember, the normal glucose level is 40 to 60, but preterm infants are at a greater risk for hypoglycemia. And what are those signs and symptoms? Look at that long list. Lots of things, but probably your very first sign is that jitteriness, and the most common symptom is the jitteriness, where their extremities show that jittering, which almost looks like tremors. Fluid and electrolyte imbalance is another issue we see with preterm infants. They need about 90 to 140 milliliters per kilo per day, and the normal urinary output should be 2 to 5 milliliters per kilo per hour. Now, we say with adults we need 0.5 milliliters per kilo per hour. And in adults, we say, adults is 0.5, and then children is 0 is 1. But in preterm infants, we need much more. And preterm infants lose fluids easily. Why? Because they have a very rapid respiratory rate many times and using oxygen faster. Their skin is more thin and permeable, so they're losing fluid easier. They have a large surface area in proportion to their body weight and lack of flexion. The radiant warmers and the heat from phototherapy lights, which they often need to be under, will increase their insensible water losses by 40 to 50% compared to if we had them in an incubator. And also we have slow development of the kidneys before 35 weeks. So if they are born before 35 weeks, their kidneys are not at total development, total function. So regulating electrolytes is a huge problem. They need higher doses of sodium because their kidneys are not reabsorbing it well, but also they may be unable to excrete sodium adequately. So the ability of the kidneys to concentrate or dilute urine is very poor. So with these premature infants, we have a very fragile balance between dehydration and overhydration. So on assessment, we need to monitor a very accurate I&O. That is very important. We need to monitor their intake. Don't forget all parenteral intake, so your IVs, any feeding tubes, as well as oral feedings. When we look at output, we need to be very careful with the urine output. We probably should be weighing their diapers on a gram scale, which is going to be the most accurate. And keep track of the amount of blood that goes out in blood draws because they're having multiple different type of labs drawn. Watch for signs of dehydration. Look at their urine output. If it's less than 2 milliliters per kilo per hour, or if their urine specific gravity is greater than 1.010, if their weight loss is greater than what you expect, look for dry skin, mucous membranes, a sunken anterior fontanelle, poor tissue turgor, elevated sodium, protein, and hematocrit being elevated. Then look for the signs of overhydration, where their urine output is greater than 5 milliliters per kilo per hour. How about the urine-specific gravity? In this case, it's less than 1.002. You'll see edema, a weight gain that's greater than expected, bulging fontanelles instead of the sunken, and they'll have decreased sodium, decreased protein, decreased hematocrit levels, moist breath sounds, and difficulty breathing. So as the nurse, you are the eyes and the ears of the physician, and you are keeping a close watch on this I&O situation, knowing that your preterm infant is at a huge risk for fluid and electrolyte imbalance. So nursing interventions, we need to carefully regulate their IV fluids, 1 milliliter per hour or less, so we don't overhydrate. And don't over dilute their IV medications. Be very accurate on your dilutions. Restrain them during IV administration, which means that we're going to use an arm board, because guess what? This is going to help with preventing any infiltration of IV fluids. And blood transfusions are sometimes needed to replace the blood draws, the amount of fluid being lost through the blood draws. The next thing we have with our preterm infants is respiratory distress syndrome, RDS. This is a major concern with preterm infants. The two things that are the last to mature in a fetus are the lungs, in other words, the respiratory system, and their suck reflex. Well, we can help them with that suck reflex. We can feed them parenterally with TPN or tube feedings until their suck becomes stronger, but their respiratory system is a huge issue. So premature infants have immature lungs because of the insufficient production of surfactant. Remember, surfactant is like a soap sudsy lubricant, and so it reduces that surface tension in the alveoli and prevents them from collapsing. And so this allows for that adequate oxygen exchange. And we can give babies surfactant nowadays, which is great, because if they don't have enough, they're going to have respiratory distress. And we can reduce the risk of RDS by giving glucocorticoids to mom before the delivery of the preterm infant. What we do is we give them an IM injection, usually 1 dose of betamethasone, and it's very effective in helping to mature the infant's lungs. So we would do that if we are unable to stop their labor process once we know that they are going to deliver. Now, their respiratory status must be observed constantly. So what will we see? What are all those signs and symptoms of respiratory distress? We've talked about these before, way back in second semester. Tachypnea. Any respiratory rate greater than 60 is tachypnea. Nasal flaring. Retractions, where the chest caves in with every inhalation. Cyanosis, remember, generalized body cyanosis, not the hands and feet. That's normal. That's acrocyanosis. The expiratory grunting, which may be very quiet or very loud. Labored breathing, and then periods of apnea. Remember that newborn infants normally have what's called periodic breathing, where they have normal periods of apnea up to about 15 seconds. This is beyond that. When we're talking about periods of apnea, these preterm babies just forget to breathe because they're not supposed to. Their condition will worsen as the day progresses if you do not treat them. And that's when we will use the endotracheal tube as soon after birth, as soon as we see those signs of RDS, and give them surfactant replacement therapy. It's very, very, very effective. They will position that baby, by the way, they'll introduce the endotracheal tube into the trachea, and then they will inject some of that surfactant down the ET tube, and then reposition the child to the other side and administer some more, and then the other side, so that it's getting down into the entire bronchial tree, so that it actually goes into the alveoli of the infant's lungs. So now, nursing interventions. The focus is going to be on collaborating with other team members, especially respiratory therapy, to manage the technical equipment and facilitate the removal of secretions. Nurses are not experts with the respiratory equipment, and so having respiratory therapy there to make sure that the ventilator is working properly is really important. We're much better at all the other things. Positioning the infant. This baby can be on its side or prone, because that will facilitate drainage of the respiratory secretions and prevent them from regurgitating. Now, we always say placing babies on their back to sleep is important, but that is a normal, healthy, full-term infant who is not being supervised. In this situation, we have a sick preterm infant who is not left alone. It is under constant observation. And we need to stress that with parents so they understand, because we tell them one thing and then they see something else. So it's okay for these babies to be in a different position because they're being monitored continuously. We need to also suction secretions and maintain their hydration, because remember that adequate hydration is going to be very, very important to keep any secretions that they have thinner so that they're able to excrete them. Excuse me. The next thing is bronchopulmonary dysplasia. This is a complication of preterm infants. It is a chronic obstructive pulmonary disease. It's a chronic condition that can occur when infants are treated with oxygen and ventilators. The thing is that they need the O2, they need higher levels of O2, and they need the ventilators when they're having such respiratory distress. However, that actual treatment that they need may cause damage to their lungs, and it results in prolonged dependence on that supplemental O2. So what do we see? What are those signs and symptoms? Tachycardia, tachypnea, retractions, and pallor that is associated with chronic hypoxia, and you see activity intolerance. So we diagnose it by looking at those clinical manifestations. They also do chest x-rays, and just the fact that infants still need O2 and they still are having respiratory problems well beyond 28 days of life. So looking at all three of those things, they're able to make this diagnosis. So how do we treat it? Well, guess what? We need to give them oxygen, which is what actually caused the problem in the first place. But we give them oxygen at the lowest pressure settings possible, and we wean them as soon as possible. It's amazing, though, that these babies who have this problem usually need oxygen for at least a year, and it may be at the very, very lowest pressure setting. We also use medications, diuretics and supplemental potassium if needed, bronchodilators, corticosteroids, and antibiotics. When we look at their nutrition, they need lots of extra calories. Now, the prognosis is very good, but they have some growth retardation and developmental delays for the first 24 to 36 months of their life because all their energies are going toward helping to overcome this respiratory problem, and they don't have any calories left and energy to go toward their growth and development. Another complication of our premature infants is intraventricular hemorrhage. Let's talk about the pathophysiology. This is when you have a rupture of the blood vessels by the ventricles of the brain. You see this much more often in those really tiny infants, those less than 32 weeks or less than 1,500 grams. And the first 2 days of life is the most common time for this to occur. It's associated with hypoxic injury to the vessels. You can have increased or decreased blood pressure and a change in the cerebral blood flow. So what do we see in these babies? They're very lethargic, they have poor muscle tone, and you start to see their respiratory status really deteriorating with cyanosis or apnea. Drop in their hematocrit levels, you'll see decreased reflexes, bulging of the fontanelles, and sometimes seizures. Now, some infants show no signs at all. Just knowing that they're at risk for it, they would just go ahead and do a CT scan. And the treatment here is oxygenation. You need to maintain their respiratory function. Also, the rest of the treatment is really supportive, dealing with treating the symptoms and dealing with any other complications that they have. So as nurses, we need to observe for early signs, measure their head circumference daily, because with this intraventricular hemorrhage, they may develop hydrocephalus, and assess them for any change in neurostatus, and it may be very, very subtle. We've said repeatedly that you all have been taught how to do a very, very thorough head-to-toe assessment on both adults and children. And yet, many times, we don't need to do that on complete, entire head-to-toe assessment with all that depth, but we need to do more of a focused assessment. Well, in this situation, this baby needs a very in-depth neuro assessment very frequently, because that's where the huge problem is. So you're focusing in on what is the issue here. The parents also need a lot of help with how to cope with many of the long-term implications that this situation has. This child may have some long-lasting developmental delays and CNS problems. Now, another complication that we might see is something called retinopathy of prematurity. What you have here is damage to the immature blood vessels in the retina, and this results in visual impairments. Visual impairment or blindness. So we have a typo here. It should not say of, it should say or. It occurs more often in infants that are less than 1,500 grams, and the cause is unknown. However, they do think it may be caused by the high levels of oxygen. These kids have had prolonged ventilation. They've also been acidotic, maybe septic, and shock. All those things have been associated with it. But because of that, we need to keep a close watch on their pulse ox levels, and we really do not want to see their pulse ox at a level of 100, because they might need 20% O2 that gets them to 100 pulse ox. However, what if you increase their oxygen to 30%? They're still going to be at 100% pulse ox. Can't get any higher than that. What if we're giving them 40% O2 or 60% O2? They're still at 100%. What we want to see is their pulse ox levels at 99%, because that is telling us they're at exactly what they need and no extra. Now, we need to screen infants who are less than 28 weeks for this, and they may be able to have cryotherapy or laser surgery. And these have been used to destroy the proliferating blood vessels. Reattachment of that retina may be necessary, so surgical intervention at some point. The prognosis here is many infants will have spontaneous regression and little or no impairment of vision. So that's really, really good. But obviously, a lot of parental support is needed here. You've got these sick, tiny little preterm babies with one complication after another, and now you're telling them that their babies might be blind. Necrotizing enterocolitis. We affectionately call this NEC, N-E-C, necrotizing enterocolitis. This is a serious inflammatory condition of the intestinal tract. Unfortunately, this is a very common complication of premature infants. It may lead to cellular death in the areas of the mucosa of the intestines. So what's going on in the pathophysiology here? You have intestinal tissue of preterm infants that is too weak for the decreased O2 levels that they had at the time of delivery. So when they start feeding, they get this increased pressure, and that stress that's going on allows the bacteria that's normally in their gut to invade or damage the intestinal wall. So what do you see? Nausea and vomiting. And this vomit is green. It's grass green vomit. They're poor feeders. They have abdominal bloating and redness of their abdomen. We all know what necrotizing situations are, where you have black necrotic tissue cellular death. That's what's going on in this baby's intestinal tract. Now, nutritional issues are another problem with preterm infants. They need 105 to 130 kilocalories per kilo per day. Remember, they have very few fat stores. They were born skinny, scrawny. Their glucose stores are used up shortly after birth, but yet they need extra glucose for brain development. And their GI tract is very premature, immature. It does not absorb nutrients as well. So they're going to need increased amounts of protein, increased amounts of iron, increased amounts of calcium and phosphorus. And they need many, many more of their other nutrients per kilogram for healthy weight gain. So we need to assess them. How are they tolerating their feedings? If they're on tube feedings, be sure you aspirate the residual. Make sure that the feedings are moving through the GI tract. Assess them for the readiness for nipple feeding. When do they start showing signs of rooting? Is their respiratory rate less than 60? If not, we're not going to do oral feedings yet. And when can they tolerate all the additional handling and holding? Do they have an intact gag and suck reflex? So many, many different things to make sure that they are actually ready for those nipple feedings. It's much easier for this infant to be fed by tube feedings until they really are strong enough for the nipple feedings. They can also have problems with their skin. Their skin is very fragile, very permeable, very, very easily damaged. And yet they have lots of IV lines, different electrodes that are being taped onto them. So use as very little bit of tape as possible, or back it with cotton. What we usually try to do is double back any tape that needs to go on them, and actually use cotton behind it, because all of this extra tape can be very damaging to their skin, especially when you're removing it. You can actually just tear off their skin because their skin is so fragile. So there are a lot of different pharmaceutical companies, different medical equipment companies that are constantly trying to improve their different types of adhesive devices to make them less damaging to the neonate skin, especially our preterm infants. Avoid alcohol and other skin disinfectants. They're just too harsh for their skin. And sometimes we actually will bathe these babies with sterile water when they're less than 32 weeks gestation because of their high risk of infection. Assess their skin very frequently and make sure that you are very, very careful with their positioning so that we avoid any extra pressure on their skin and any risk of nerve damage. Now, they also have problems with infection. The incidence of infection in preterm infants is anywhere from 3 to 10 times greater than full-term infants. And we know that full-term infants have a higher risk of infection than adults and older children. So what's going on here? You've got many, many factors that are contributing to this. You have maybe exposure to maternal infection. That may have been what put her into preterm labor in the first place. You have lack of transfer of the immunoglobulin G from the mom during the third trimester because it hasn't occurred yet, and that helps with their immune system. You have an immature immune response in a preterm infant, and they are just being subjected to many, many invasive procedures, which increase their risk for infection. And in addition, they have a very prolonged hospital stay. We know the last place that you really want to be is in the hospital because we have so many more pathogens that we pass on to our patients. So nursing care, we need to be very, very, very focused on cleanliness, that infection control issue. Maintain the infant's skin integrity so we don't have any risk of portal of entry. Exposure to the contagious diseases needs to be avoided, and watch for those signs and symptoms so we can identify early when we see signs of infection, so we can jump in and intervene very, very early. Now, problems with pain. Those babies, those tiny little NICU infants, are undergoing many painful procedures. And you know what? We once thought that preterm infants were too neurologically immature to feel pain. In fact, we thought full-term infants couldn't really feel pain. But we now know differently. We now recognize that the pain stimuli causes physiologic and behavioral changes in these infants. So what will you see? When they're in pain, you'll see an increase in their intracranial pressure, and this increases their risk for intraventricular hemorrhage. You'll see a painful response when you touch them. You see changes in their heart rate and their respiratory rate, an increased blood pressure, decreased O2 saturation. You'll see metabolic changes, high-pitched, intense crying. They'll squeeze their eyes shut very tight. They have tense, rigid muscles. You'll see rigidity or flailing of the extremity, many different color changes. They can have red skin, dusky skin, pale skin. But they also, after some repeated exposure to pain, may not be able to show behavioral changes at all at that point. So be aware that they do undergo painful procedures. They do exhibit signs and symptoms. We do need to help them with that. So nursing intervention that we can do with this, prepare them for those potentially painful procedures by waking them very slowly, very gently, being very careful with them. Keep their extremities near their body. Holding their arms down at their sides really helps them to feel more comfortable. And many times it's helpful to have one hand near their mouth so that they can suck if they want to. We can put some sucrose on a pacifier. We have something in the nursery called Sweet Ease, which is sucrose that we put on a pacifier. Talk softly to them, hold them, and rock them prior to the procedure, during if possible, and certainly afterwards. And we do have pharmacologic things we can use for them. We've got opioids such as fentanyl. It's well tolerated by preterm infants. We have NSAIDs that we can use, and we have sedatives for agitation. So if we see a lot of those signs and symptoms, these kids need to be treated for their pain. Now, problems with environmental stress. Preterm infants very, very commonly have difficulty with stress. They cannot handle the usual NICU environment. They cannot stand the bright lights, the noise, the alarms, all the doors in and out, and all the different people, and all the different handling that's going on. So we need to limit. We don't want to do everything at one visit into their room because then we stress them out too much. But we do want to try to clump and do a few things together. We try to keep the lights dimmed, or we'll put like a blanket over their isolette so that we have decreased some of the lights. In the Aspirus Birthing Center, they have a noise alarm system, and there's a light in the ceiling, and as long as that light is green, that noise is at an okay level. But when it gets yellow, it's like, we better start being careful. And once it's at red, that level of noise is way too loud. You get a physician, a nurse, a parent, and a respiratory therapist in that room at the same time talking with each other in a normal voice, and you probably have a red alarm on the ceiling. So we don't realize our normal conversation and how loud that may be for infants. Now, stimulation of any kind can cause them to have increased energy expenditure, and anytime they're using energy and calories for something else, it's not available to them for their growth and development, which is what we need to be occurring. And although touch is usually comforting to infants, preterm infants often associate touch with painful procedures because they undergo so many. And so they can develop something called touch aversion. If we do too many frequent interruptions of their sleep, we're going to interfere with the development of their normal sleep-wake cycles. And so routine nursing interventions often can cause changes in their heart rate, their O2 sat levels, and their behavioral states. So as I mentioned before, you do not want to do every single thing possible that you can when you go into their room, but clump things together and keep an eye on their symptoms. Do you see any signs that this baby is becoming stressed by the environment? Then back off, get done quickly what you need to, and get out of their room and let them have some rest time. So, nursing interventions. We will focus on providing developmentally supportive nursing care that will meet the preterm infant's ability to tolerate the stimulation. As I mentioned, schedule the care, group the care that you need to do so several tasks can be performed at the same time, but not everything that needs to be done in that shift. Reduce the stimuli. Keep all types of stimuli to a minimum. Promote rest. Actually schedule quiet periods and do not disturb or let others disturb the infant. Promote motor development. So change their position every 2 hours and avoid the supine position for these infants. Individualize their care, so adapt their care according to their signs and symptoms, according to their ability to tolerate it, and communicate the infant's needs. So use the Cardex to inform all other care providers about the different techniques that have been effective. This is where we're going to end this first class recording. So all of the things we've talked about are specific problems to our preterm infants. And then the second half of this will focus on all the other high-risk neonate situations, and we'll be starting with the post-term infants. But here ends the first half of Learning Plan 9, High-Risk Newborn Care.